Good evening everyone, welcome back to my YouTube channel. Again, before we start, I have to remind you to subscribe and then the notification button, hit it so that whenever we upload a video, you don't miss. Remember, we pledged to give lectures on physiology, starting with cardiovascular physiology, and now we are here. I promised again that every Saturday or every weekend to be uploading a video on physiology or clinical topics. So for now, we are handling electrocardiography, and then physiologically we are on cardiac cycle. Now we are going into advanced topics in cardiac cycle, which are not taught most of the times, but very important in clinical practice. So today we are going to be looking at pressure volume loops, and then determinants of myocardial performance. Myocardial performance, we are more concerned about today, LV. And also pressure volume loops, we are looking at that of left ventricle because it is the most important. Right ventricle is also important, but not as left ventricle. Whenever the left ventricle fails, the patient can die. The time it takes for the patient to die, it is shorter compared to when the right side has failed. But both of them are important. Again, just remember to subscribe. Yeah, let's start. We are starting with the pressure volume loops. What are pressure volume loops? So pressure volume loops, so it is just a presentation of pressure and volume as they change during the cardiac cycle. Yes, you see, cardiac during the cardiac cycle, that is in real time if you need it. So the time here we don't see it, like the time component, how long is this? No, it doesn't. So this one, it shows the effects of loading conditions. And inotropic state. Inotropic states on myocardial performance. You see how the two are linked? The two topics are linked. So this is a continuation of the cardiac cycle. So here it is, we are just representing the pressure versus volume, or volume versus the pressure. And the loading condition, what are the loading conditions? We are going to see them preload and after load. We are going to also clear that concept. So in the depiction of the pressure volume loops, the times of different phases of the cardiac cycle, they are not labeled, they are not shown, but what we show, they are the phases. The phases, they are shown, and then the certain volumes and the effects. So let's see how it looks like. This is a curve. These are the pressure, the curve, different curves and phases of the pressure volume loop. Pressure and volume. So what do we have? We have, this is a graphical presentation. We have the y-axis, the y, and then the x-axis. We have these two as usual. Now, what do we have here? We have LV, pressure, left ventricular pressure, and then here we have LV, volume. This is a labeling. If you know the cardiac cycle or the phases, you don't need to struggle with this one. This is so simple. But if you don't know, then you need to cram it, getting mnemonics, what, all those ones are useless. You just have to read the phases of the cardiac cycle and then get this one done. Just need the starting point and then the end point. The starting point, we can say this A is the starting point. Then we label the cycle. We are talking about a cardiac cycle. This is as B, C, and then D. We have labeled them. So what do we have? We have phases, different phases. And you can say this is the feeding phase, and then this is ejection phase. Ejection phase, feeding, and then ejection. How do we know that ejection? You have to indicate with an arrow. That is an arrow, and then the feeding phase, still an arrow. Then we have these vertical lines. This, if you look at x-axis, we have volume, y-axis, we have pressure. If you go this side, see this is a curve that curves downward and then keeps rising so slowly. It curves down and rises so slowly. So on the x-axis, on the y-axis, pressure is increasing but to a low extent. And on the y-axis, volume is increasing. See what we have moved, and then up to a certain point B, where we get the vertical line. So feel, next phase of the cardiac cycle is the isovolumic contraction. You remember, if you watch the video, isovolumic contraction. Why? The line is vertical. It has a change in pressure, but no change in volume. Change in pressure is there from here up to this point. From this point up to this point, change in pressure is there, but no change in volume. Volume remains here. Yeah, this is isovolumic contraction. And now we have another, after ejection, we have another vertical line. Another vertical line where there is a change in pressure from here up to here, but there is no change in volume. And this is isovolumic relaxation. We finished this one. Isovolumic relaxation. All these are not new. So what do we have after isovolumic relaxation? Isovolumic relaxation is followed by mitral valve opening. So we are labeling at point A. What happens at point A? We have mitral valve opening. What happens if it opens? Blood from LA fills the left ventricle, and now this is why this curve is rising up. And because of feeding, left ventricular pressure increases, but not so much. If it increases very fast, then something abnormal is there, like maybe diastolic dysfunction. Pressure should increase in LV during feeding, but very, very less. If it is steep, if this curve becomes steeper, maybe like that, there is diastolic dysfunction. Otherwise, we don't need this. It should increase, but at a small extent. So mitral valve opens. Next point, A to B, we have feeling. We already labeled that one. If it comes in the exam, you should produce this thing. Feeling phase up to a certain point, point B. What happens at point B? Before isothermic contraction, or to cause isothermic contraction, is mitral valve close. Mitral valve has closed at point B. Mitral valve has closed. Why do we say it has closed? Because we don't see any change. Otherwise, this line can continue upwards depending on the preload. Again, this line can continue, can be extrapolated upwards depending on the preload. And also this line, the green one, can be extrapolated downwards depending on contractility. Depending on contractility. So BC, we labeled it already. BC is the isovolemic contraction. There we generate enough pressure to open the aortic valve. That is from the normal cardiac cycle. At point C, what happens? Point C, aortic valve open. After opening, what happens? CD is the ejection. Ejection, and point D is the aortic valve closes. These are the labelings of the phases. Now, this is not enough. At point B, see, at point A, we have something else, something different. Mitral valve opening, yes, it has opened, but what do we have at this line here? If you extrapolate this line on the volume curve, we have something called LV and systolic volume. LV and systolic volume. And then when the mitral valve closes, if you extrapolate this line to go to the volume axis, on the x-axis, this is end diastole. So we have LV and diastolic volume. We have this at this point. This point is end diastolic volume. At this point is end systolic volume. Now at this point, if you extrapolate this line to the pressure axis, we have LV and systolic pressure. And then if you extrapolate this line from the closure of the mitral valve up to this point, we are going to have LV and diastolic pressure. This is advanced cardiology now, these labelings, LV and diastolic pressure. Now, if you go extrapolate this point D to the pressure line, it is going to give LV and systolic pressure, LV and systolic pressure, and at point C, we are going to have point C. Mitral valve is opening, so the peak systole is happening here, somewhere here for this curve. So if you extrapolate this point, ejection is going to start from here, but peak systolic pressure is going to be somewhere here at the top of this curve. So if you extrapolate it you're going to get at this point LV, peak systolic pressure. Now there's this dotted line here. It's labeled as LV and systolic pressure volume relationship. And systolic pressure volume relationship. So this is the full labeling of everything of this curve, and maybe just from here up to this point, this is the stroke volume. Stroke volume, this is the blood we are ejecting. So from here, from what we see, stroke volume is from here up to here. So we get what is here on the volume axis. From the above, we are going to conclude that stroke volume is equal to LV and the diastolic volume minus, because it is the bigger one, LV and systolic volume. This is the equation for, or the formula for finding stroke volume. So one of the clinical applications of these pressure volume loops is to find stroke volume, and then if you have stroke volume and you know the heart rate, then you can find cardiac output, which is stroke volume times heart rate. You see, this is one of the clinical applications to find cardiac output. PV loops applications. Clinical application, they are the one is that, two is that. If you have the stroke volume, you can then find cardiac output. Two, see, these curves can be altered by different factors. These curves can be altered by different factors. One of them I've already said. Like, for example, we have these two words, preload and then afterload. Preload and afterload. What is preload? Preload simply is the amount of blood in the ventricle that the ventricle is supposed to pump out. Simply amount of blood. If the amount of blood is very high, like, and the diastolic volume increases, so this is the preload. To put matters simple, is the preload. We are simplifying. Preload is this one. So if LV EDV is increased, for example, instead of being at this point, it is at this point. In this curve, it's here, but if it is increased, maybe to go up to this point, what has happened to the pressure? It is going to, instead of being here, it is going to be here. It is going to be here. What did I say to this curve? The more the LV EDP, the more the LV EDV, the more the LV EDP. That is end diastolic pressure. If end diastolic volume increase, then end diastolic pressure also increases. But in the normal heart, this one, it increases up to a certain point. In the normal heart, see, from this point B, the increase is steep. The increase is steep in pressure now. The increase is steep, but not in volume, because like at this point in normal hearts, it is supposed to be around 150 ml. LV EDV in the normal heart, it can be around 150 ml. And that is why if we, like in echocardiography, we measure LV in the diastolic volume on M mode, what we find the normal one, it will be around 160, below 160. below 160, 90 around to 160. So all this range is there. So what happens above 150? What happens above 150? Before 150 is approached, this curve is like this: a minimal increase in pressure, but a large increase in volume. We need that one. But after a certain limit, then the increase in pressure becomes steep. Like maybe instead of 150 it is 180. The increase in pressure will be steep. 180 is around here maybe. A small increase in volume is accompanied with a large increase in pressure. We don't want that, and that one will shift this curve towards the left. This is the right, this is the left. No, this is the left, this is the right. So if this curve is moved in this direction, it becomes steep. If curve, that is AB becomes stiff or steep, not stiff, steep, two things can be there: either diastolic dysfunction or increased LV EDV, which increases LV EDP. If this curve shifts to the left, to the right, that is a normal response. If it goes this side towards the right, that is a normal response in a normal heart. But in abnormal heart, the diseased hearts, it will shift to the left. We don't want that one. So another application of this is to evaluate diastolic function. We evaluate diastolic function using this loop curves at curve C, at curve AB. So another one is if, see, normally the normal ejection fraction is supposed to be at least 54 to 74%, and then 52 to 72%. These are females, and then these are males. Normal ejection fraction, EF, ejection fraction, is supposed to be this, meaning if I was LV in diastolic volume, if the LV in diastolic volume is LV and diastolic volume is around maybe 120 ml, and then LV and systolic volume is we are calculating simple calculation is around 60 ml, meaning how many mLs have gone? The mLs which have gone, 120 minus 60, it will be stroke volume will be 120 minus 60, which is 60 ml. So 60 ml. What is the percentage of this? So to convert this in percentage to get the ejection fraction, otherwise stroke volume is this. So ejection fraction, stroke volume is the blood that has left the ventricle, the LV in this case, in one beat. So ejection fraction is how much of end-diastolic volume has been pumped out of the LV. So how much in percentage? So to convert this into percentage, we are going to get 60 EF. 60 over 120 times 100. And this one will be 1. It will be 5, which is 50%. Otherwise, the formula for EF is going to be LV E dV minus LV E and systolic volume, yes, and systolic volume over LV and diastolic volume times 100%. That is the formula for ejection fraction. I'm giving you all these ones. These are basic concepts we are getting from this pressure volume loop. Now, for example, this LVDB was 1 to 150, and then we find that LV E SV is here. This was 120, this was 120, but this LV, so this 50%, this is, if ejection fraction is 50%, again, ejection fraction is 50% is below the normal one for females and males. So this is reduced ejection fraction. In this we say EF is reduced, is decreased, EF is decreased. So we don't need this one. So in this case, we need maybe around like 80%, 80 ml to be pushed out, to be ejected, or 90 to be ejected. If it's 90, instead of if it's 90 ml, then it shall get stroke volume as 120 minus 90, which is LV and no. If it is 30, for example, 30, which is 90%. If LV and systolic volume is 30 ml, then ejection stroke volume will be 90, which is 120 minus 30, which is 90. So EF will equal to 90 of 120 times 100. And then this is 3. 15. Yeah, to be 15 by 15, 4 by 15, 90 by 15, that is, I think, 6. Yes. So by 2, 2 by 2, 3. By 15, 12 by, no. What is wrong with me? EF will be 90 of 12 times 100, 120, so 12 by 4, that is 3, and by 4, here by 2, okay, say by 2, 6, by 2, 5, and by 6, 1, by 6, 15, yeah, 90 over 120, 0, 0, then here by 6, or by 2 it will be 6, by 2 it will be 10, or 5, and then by 6, 1, by 6, 15, 15 times 5, that is 75. So EF, in this case, if LV and systolic volume is 30 with LV and diastolic volume of 120, EF will be 75%. So if like maybe when it is here it is 30, here it is 120, and then if it's here it is 60. So if it happens like this, we can judge the systolic function. So EF is measuring the systolic function. Systolic function of the heart. So if we can find EF from these ones, like here, then pressure volume relationships or loops. Fourth, it can evaluate systolic function. By how? Finding EF and the stroke volume. Understand? So this is a clinical application. Another one is, so if systolic like LV dysfunction is there, like systolic dysfunction is there, this will shift, this line, it will shift going this side, will shift to the right. In case of systolic dysfunction, LV systolic dysfunction, the line will shift to the right, and then with normal or increased LV systolic function, increased LV systolic function, then it will shift to the left. It will decrease end systolic. If we decrease end systolic volume, good systolic function. If we increase, we have increased LV systolic volume, then it is dysfunction, systolic dysfunction. If we have increased LV EDP, is diastolic dysfunction. If we have increased LV EDV, it is increased preload. Either we have increased blood volume, we have regurgitations, like valvular diseases. So finding an increased LVDV can be because of valve diseases, or just increased compliance like in normal hearts or cardiomyopathies, like dilated cardiomyopathy, where the cavity, LV cavity is increased and then its volume is increased. So cardiomyopathies can cause that. The next clinical application is, you have seen if it shifts this side or this side, this side or this side. So this one, if it shifts this side, it makes it narrower. Preload is same, like preload is same, but increase in LV and systolic volume, narrower shape, and then LV dysfunction. If this curve shifts to the right, increased LV EDV, it can be normal or cardiomyopathies or valve diseases. Now if this curve, like here, if this point is too high, like this point is too high, this one, if we label it, can be the afterload at this point. So the LV has to generate this pressure up to this point to start ejecting. So this is point C, we have afterload. In systolic, in isovolumic contraction, the LV should generate this pressure until when ejection happens. So ejection will not happen until when the ventricle, the LV, has generated the pressure that is outside the ventricle, and that is aortic pressure. For example, in systemic, in hypertension, HTN, aortic pressure is high, nah? Is high, increased. Instead of 120, it is around maybe 180 if not controlled. And if it's chronic, 180 millimeters of mercury. So to inject blood, the LV in normal conditions, it is supposed to generate only 120. So for example, if this is 120 millimeters of mercury. Where is 180? 180 can be this side. This side. So if you extrapolate this. So in hypertension, where the pressure is 180, this vertical line will continue up to this point. So this is extra. So the LV is supposed to generate extra 60 millimeters of mercury before it ejects. So if we find that this point C is shifted upwards, point C shifted upwards, it is increased after load. So the conditions can be systemic hypertension, aortic stenosis, those ones can be there. Yeah, so we can evaluate 5 valve diseases, e.g. aortic stenosis, aortic regurgitation. Like in regurgitation, because remember in regurgitation, we have isovolumic relaxation in normal. But in regurgitation, where the aortic valve should close, here it is closed. That's what we said at point D. In regurgitation, the valve cannot close properly. So what happens? Some blood leaks from aorta into the LV. So what happens? This line, it will not be truly isovolumic. It will shift also to the left. It will be slanting. It will slant instead of being isovolumic, it will be slanting. If it is here, this is not isovolumic. Otherwise, point D is here, and then for it, point A is here. So this difference is there. So what happened? This blood, this volume came during isovolumic relaxation. Should be isovolumic, but no isovolumic relaxation in aortic regurgitation. So this one, we shall see it if the loop loses the shape. This one, this line DA becomes slanting. If it becomes slanting, then aortic regurgitation is there. And what will be the effect? The effect, this one, this point B will also be shifted upwards, because an excess of like maybe aortic regurgitation brings in around 30 ml, and the normal pulmonary venous return, it is bringing the normal thing, which is maybe around 90 ml, then plus the end systolic volume, which is systolic volume 30. So in this case, it will be 120, it will be 150 ml. Regurgitant volume plus the normal volume. We don't need this. So regurgitant volume, it will, the feeding will start when it already 60 ml is there, and then it adds. It will add 90, which is coming in. We don't want that one, so to make it 150, we don't want that one. Yes. So we can use to evaluate valve diseases. 6. Assess the effects of preload and after load. Assessing the effects of preload and after load. See, we have assessed already, like afterload, hypertension, HTN, and aortic stenosis. They contribute to afterload. Aortic regurgitation, AR, aortic regurgitation, AR, and then mitral regurgitation, MR, contributes to preload. And then also IV fluids. IV fluid also contribute, whether you're giving IV fluids or not, you're contributing to preload. So you assess the effects of preload on cardiac, assessing the effects of preload on contractility or performance. So when we see that, okay, increased contractility is there, increased contractility, like inotropic support is there. What are inotropic supports? Inotropic support is, or inotropic state is a state of contractility. We just say contractility. Inotropic state is a state of contractility. Is contractility high or low? So if contractility is high or low, then we have to assess preload and afterload, because they affect it so much, and contractility is equal to performance. If contractility is low, low performance is there, cardiac performance is there. If contractility is high, then good cardiac performance. So this is the next topic, no? This is the next topic. Then another thing clinically is to guide. We can use this one to guide therapy. Seventh application, to guide therapy. If we assess preload and afterload, we can choose, you can decide whether to give IV fluids. If we see that preload, that is a decrease in LV, EDV is there, then you can give preload, like we can give IV fluids like NS to increase the preload, because cardiac performance can be reduced due to decreased LV, EDV. We shall see that when it comes to Starling law or Starling mechanism, Frank Starling mechanism. We shall see that a decreased preload can decrease the performance. And then if we assess that the afterload is much, like here we see point C, and we take the pressure. If the pressure has decreased, maybe to, instead of 120 it is 8, afterload is less, maybe there is systemic vasodilation, so we need to give a vasopressor. We have to give a vasopressor, because if afterload is 80 in a normal heart, meaning cardiogenic shock is there, so we have to give vasopressors. If maybe it is too high, and maybe during the case, like first we go to cath lab, during the case you see systolic pressure, it has decreased, that is systolic pressure here, systolic pressure, it has decreased, then you have to give NORAD. That is a vasopressor. If it is too high, then stop NORAD. So in many ICUs and maybe CCUs and cath labs, these they are used to monitor real time, and then decide precisely whether to give fluids, whether to give inotropes, whether to give vasopressors or not. But the problem with this one, like how to measure it, that is where the problem is. How are we going to measure this one? It is so important theoretically, so important, but its clinical application is limited due to one, expensive equipment required to measure or to record the pressure volume loops. So the equipment we use, like this one, PV loops, can be recorded with conductors, catheters. Conductors, catheter, meaning we have to be in cath lab, insert the catheter via the arterial system, go to LV and measure what it is supposed to measure. But these catheters, they are very expensive. They are very expensive, so many centers, they don't have them. So even if you may be there 20 years in cath lab or 20 years working in CCU or ICU, but you have never seen this, because the equipment, the catheter that is required, the system, it is very expensive. So many centers cannot afford it. Only highly specialized centers can afford it. And also, some doctors, they don't know how to interpret these ones. They don't know. They are not trained for that. You can even ask them, you find they don't know how to interpret this. So, expertise, equipment, like price of the equipment of the system, and expertise, they limit its application, but it's very important. So instead of this, what do they use? This is an invasive test. This is an invasive. Remember, we have to enter the arterial system and then go to LV, meaning invasively. There are some non-invasive measures, like using echocardiography, point of care echocardiography, like bedside. We use that one, we can estimate ejection fraction, stroke volume, cardiac output, everything. We can estimate preload and afterload, and then decide whether we can give fluids or not, like if we use IVC collapsibility index. In IVC collapsibility index, we look at IVC, whether it is collapsing or not, dilated or not. If it's dilated and non-collapsing, fluid overload, that is increased LVEDP, will be there. Don't give IV fluids. Yeah? If it is collapsing and narrow, small and collapsing, meaning volume depletion, you give IV fluids. Volume replacement is required. So very fast. This one is not fast. It is not fast, but the other ones, using ultrasound, using echocardiography, very fast. And then also BP measurement. Non-invasive, using non-invasive BP monitoring. You just take the BP, systolic pressure. If no systolic pressure, less systolic pressure, meaning decreased afterload. So we need to give vasopressors. Without this, otherwise it is precise. It is precise, and those highly specialized in affluent countries, rich countries, they use it. It is so good, they use it. Yes. So with the pressure volume loops, we have finished. We have finished it. What we have seen, it is this different points. You don't need to cram this, because this is basic physiology of the cardiac cycle. What is not basic is the concept of LVEDP and LVEDV, LVSV, LVESV. Those ones are not shifts. Yeah. So in case of increased contractility, this one will go up this side. Yes, and how it is clinically applied. So the next we go to determinants of myocardial performance.